Why and How, Nutrition for the Extremely Low Birth Weight Infant. My name is Emily Kanata, and I will be your moderator today. Before we begin our event, I would like to go over a few housekeeping items. We encourage you to ask questions throughout the presentation, so please submit your questions on the questions panel. We will review your questions at the conclusion of the presentation. Use your computer speakers to adjust volume. We have detailed slides, so please feel free to use the full screen feature found on the top right corner of your webinar screen. Don't forget to download your certificate of attendance and provide feedback about this program. This presentation will be available on demand at the conclusion of the event. Information on how to access the recording will be emailed to you. It is my honor to introduce our speaker. Mindy Guzezi is a registered nurse with over 37 years experience caring for infants in the NICU setting. During that time, she has worked as a bedside nurse, a neonatal maternal flight nurse, a nurse manager director, and NICU specialist. She was instrumental in bringing the exclusive human milk diet into her facility and helped develop their feeding protocols. Mindy is an expert content reviewer for A1's Neonatal Orientation and Education Program, is certified in both neonatal intensive care and inpatient obstetrics, has a neonatal developmental care specialist designation, and is a board-certified medical science liaison. Welcome, Mindy.
Thank you for that introduction, and thank you everyone that's joining today to talk about the who, why, and how of nutrition for the extremely low birth weight infant. I do have a few disclosures to share before we get started. I am a current employee of ProLacto Bioscience. I'm also a current employee of Logan Health Medical Center. I have independently prepared this presentation, and any photos or diagrams that you see in this presentation are for educational purposes only. They are not any recommendations for any particular product. My objectives for this presentation are to help you understand who benefits from the use of a standardized feeding protocol that includes the use of human milk, to discuss the reasons why the use of human milk benefits the extremely preterm infant, to describe how feeding practices impact nutrition delivery to the premature infant, and then discuss outcomes that are associated with improved infant nutrition. Let's start with the who. Who am I talking about when I say extremely low birth weight, or in some cases, extremely low gestational age infant? Well, who I'm talking about has a different meaning than it's had in the past. The age of viability has changed, and it continues to change. When I began my NICU career, as I said, almost 40 years ago, survival at 30 weeks was kind of a big deal. It was something to talk about, something to brag about. Now, less than 15 years ago, the chance of survival for a 24-weeker was only about 20%. Now those babies are routinely surviving. And actually about 37% of those born at 22 weeks, barely halfway through their gestation, are surviving. Most of us are experiencing a very new population of premature infants in our units than we were seeing just a few years ago. When I talk about extremely preterm infants, generally I'm talking about those born at less than 28 weeks gestation. And really, for all intents and purposes, they could still be considered fetuses. Growth and development that should be happening within that nearly perfect intrauterine environment, we're really now trying to replicate in our NICUs. We're having to learn a lot as we go along because care of these infants really is a new frontier in medicine. Unfortunately, high rates of mortality and morbidity are consequences of being born this prematurely. Severe complications such as chronic lung disease, necrotizing enterocolitis, retinopathy of prematurity, late onset sepsis are not common in this population, and really they are iatrogenic. They're a result of the environment these babies are born into and what we need to do to keep them alive. And unfortunately, these complications often have lifelong implications. Along with the physical consequences of being delivered extremely early, there are financial consequences. Average hospital costs associated with care of these infants is about $3,500 a day if there are no complications. NEC can add $74,000, almost $200,000, depending on whether it's medical or surgical NEC. BPD can add over $31,000. ROP requiring surgery, more than $35,000. And these don't include long-term costs. It's been estimated that lifetime cost for some of these infants is up to and exceeding $4 million. Several studies have shown that the adoption of standardized care protocols, including feeding protocols that promote the use of an exclusive human milk diet, is cost-effective as well as improves survival. But of course, we always want more than just survival. We want best outcomes for our infants. One of the issues that many babies born at these early gestational ages experience are neurodevelopmental delays, including delays in cognition and issues with their motor function. That really shouldn't be unexpected, since in utero, the fetal brain increases in mass 5% every 48 hours, which I find to be incredible. What's even more dramatic is the development of the cortical surface area, those ridges and valleys in the brain that are responsible for motor and sensory function. And those areas increase exponentially in the last trimester of pregnancy, right at the time that we have these babies in our NICUs. In regards to nutrition, the preterm brain consumes the greatest amount of nutrient resources for its function and growth than any other system in the infant. It's really difficult to replicate that degree of nutrition that would normally be provided by the placenta when we're trying to feed these infants that, as I said, really are still fetuses. Now let's look a little closer at why. Why is optimal nutrition so critically important for this population? I'd like you to remember this quote from Dr. Alan Lucas. Feeding the very low birth weight preterm infant is not a natural physiological process. These infants aren't supposed to be digesting and absorbing nutrients through their GI tract. They're supposed to be nourished by the placenta. They're supposed to have only amniotic fluid in their gut. Unfortunately, we really have no other option at this point than to feed. And we have to do the best we can with the knowledge and resources that we have available, keep up with the research, and move forward as we can. Many factors play into what's been called the nutritional emergency that occurs in these extremely low gestational age infants when they're delivered. As I said before, that last trimester of gestation is a period of incredibly rapid growth and maturation of every organ system. Consequently, infants born at this stage of development have really incredibly high nutritional needs, 2 to 3 times that of the full-term infant. They haven't had that time in utero for protein, fat, and glycogen accretion. They're born with really no reserves to rely on at all. A nutritional deficit begins to occur immediately after birth, and that deficit is exponential if we're not able to provide adequate nutrition to that infant. This deficit occurs during that critical period of development, which is especially impactful on the brain. Actually, about 70% of every calorie taken in by this infant is used for growth and development of the brain. A recent study out of Japan supports the correlation between nutrition and neurodevelopment. This study included over 13,000 infants that were born at less than 32 weeks gestation. And it showed that early initiation of enteral feeding, early achievement of full enteral feeding, and then good nutritional support were associated with improved long-term neurodevelopmental outcomes, as well as improvement in visual and hearing outcomes, and also impacted the need for home oxygen therapy. Another study, this one out of Switzerland, demonstrated a direct correlation between enteral macronutrient intake during the first 2 weeks of life and brain development. Enteral energy and macronutrient intake predicted brain growth and white matter maturation, and this brain growth correlated with psychomotor outcomes at 18 months corrected age. Also, I find it interesting that the smaller brain volume that's sometimes associated with mechanical ventilation was actually mitigated with higher energy intake in that same preterm period. Another organ system directly impacted by this nutritional emergency created by preterm birth is the GI tract, which is certainly no surprise to anyone working with these infants. These babies experience slow motility, disorganized peristalsis, and delayed emptying of the gut that alter the absorption kinetics of the nutrients we're trying to provide. Gut bacteria colonization is also disrupted. This leads to dysbiosis, a mismatch between the good and the bad bacteria. This can alter the functional, the immune, the neural, and the barrier development of the GI tract. So what you can end up with is a poorly functioning leaky gut, a poorly functioning immune system, and a setup for GI complications, including feeding intolerance and neck, sepsis, and impaired growth. The earlier the infant is delivered, this is no surprise, the higher the risk to the gut. You can see from the study by Yi and colleagues, the majority of NET cases seen here in the lavender are seen in infants that are born at 29 weeks or less. Now, notice where the peak onset of NET is. It's way out at about 32 to 33 weeks post-menstrual age. So remember this, when your 24-weeker is now about 6 weeks old, doing well, don't be lulled into a false sense of security. This is when NEC occurs in the majority of these babies. Also notice in this study that there were very few cases of NEC in those that were born at 23 weeks. Well, that's because when this study was done about 10 years ago, there were very few 23-weekers that actually survived long enough to develop NEC. Premature infants are under a great deal of physiologic stress. All of them will have generalized inflammation, whether from delivery, a disease process, or from the many procedures and the treatments that are required just for their survival. They have gone from a very low oxygen environment to one that's relatively high in oxygen. So they have increased production of reactive oxidative species, and their defenses, their antioxidants, are deficient. Inflammation and oxidative stress contribute to cell and tissue damage, organ injury, and this results in the major morbidities of prematurity that we see: ROP, BPD, NEC, PDA, and neurodevelopmental delays. Early adequate nutrition is imperative for this population. But how are we going to support these infants that really shouldn't even be eating yet? Well, parenteral nutrition. Parenteral nutrition in the first few hours after birth is imperative for the very preterm infant. For most of us, that means a starter or a stocked TPN that we have on hand for emergencies because, as we all know, babies don't arrive in the NICU according to your TPN ordering schedule. These infants should be started with amino acids at 3 grams per kilo per day and lipids at 2 grams per kilo per day, and then advancement to 4 grams per kilo per day of amino acids and 3 grams per kilo per day of lipids on that following day. Approximately 50% of growth failure in the NICU is related to inadequate provision of protein and fat. Inadequate protein intake results in cumulative deficits, leading to poor growth and delayed maturation of organ systems. And once there is that deficit, the catch-up can be next to impossible because of that cumulative effect. Essential fatty acid deficits can develop in less than 72 hours if adequate non-protein energy isn't provided. If not provided enough non-protein energy, those fatty acids will be used for energy rather than brain growth and development that they're supposed to be doing. Lipids and proteins also provide substrates for the production of glucose. Remember, these babies haven't had the opportunity to amass a store of glycogen. Fat and protein are used in gluconeogenesis, and they help maintain normal blood sugar levels. Now, in the past, there's been a reluctance to use lipids or to increase too fast based on early suggestions that lipids might increase lung disease, might displace bilirubin from albumin, might cause central nervous system injury, or exacerbate sepsis. In reality, the data supporting these are either lacking, have been misinterpreted, or really are non-existent. And studies have shown that the provision of lipids for these infants really is critical, especially for their neurodevelopment. In addition to providing parenteral nutrition on that first day, actually in the first hours of life, immune therapy using colostrum should begin. Colostrum is loaded with bioactive components that are not only immune boosting, but are anti-infective, antimicrobial, and antioxidant. To provide oral immune therapy, colostrum is placed in the cheek pouches and is absorbed via the oral pharyngeal associated lymphoid tissue or the olfat tissue. You can provide this either through use of a syringe if you have enough colostrum, or a sponge-tipped applicator if you only have a few drops. Cotton swabs should not be used because cotton swabs absorb the colostrum and actually hang onto it. Very little gets onto the mucosal tissue where it needs to be for absorption. And you might get some of those little fibers from the cotton swab stuck in the mouth. So the use of a syringe or the use of cotton-tipped applicators really is recommended for this purpose. How else can we help mitigate this nutritional emergency besides early parenteral nutrition and early oral immune therapy? Well, the use of standardized care protocols has been shown time and time again to improve outcomes and be financially beneficial. And this holds true for the use of standardized feeding and nutrition protocols as well. Adherence to feeding protocols, especially those that encourage the use of human milk, has been shown to encourage earlier feeding, to decrease the risk of intolerance, and to reduce the incidence of NAC. Remember that these infants are, and this is to quote Dr. Underwood, an evolutionarily new population of very premature infants. Their nutritional needs really are best met by the use of appropriately fortified human milk. So if we're going to try to provide early optimal enteral nutrition, how should we begin? Trophic feeds or minimal enteral feeds should begin at 10 to 20 mils per kilo per day, really within the first 24 hours of birth as early as possible if the infant is stable. Umbilical lines and low-dose pressors should not be contraindications for beginning feedings. Without stimulation, the gut villi will begin to atrophy very quickly. Early feedings stimulate the gut. They promote metabolic adaptation and encourage enzyme production that is needed for digestion. The first choice for feedings is always mother's own milk, with donor milk being a backup if mom's own milk is not available or for some reason mom's own milk is contraindicated. According to the Academy of Pediatrics section on breastfeeding, formula should not be a backup for mother's own milk for those infants weighing less than 1,500 grams. And for those extremely low birth weight infants, units should consider the use of an exclusive human milk diet, meaning that all protein, all carbohydrates, all fats come from a human milk source. I don't think anyone would argue with this quote that, with few exceptions, mother's milk is the best food for a baby. There is nothing just as good. This is actually a quote from the Home Physician and Guide to Health that was written in 1923. And really the importance of human milk for human infants was recognized a long time before that. This is not new information. Millions of years of evolution have shaped mammalian milk into a very species-specific nutrition that is designed for the optimal development of that particular species. Milk for a mammal that is supposed to be a physical adult weighing hundreds to thousands of pounds within a year or two is certainly much different than milk designed for a species that grows massive brains first and then physical growth over many years, such as humans. We now know that human milk is a dynamic, ever-changing biologic system that develops along a continuum. The first is the womb milk. It's that nourishment that the embryo gets even before the development of the placenta. And next comes the amniotic fluid. The fetus actually ingests amniotic fluid in fairly large quantities, starting as early as 11 weeks gestation. Then comes the colostrum, which is very similar in composition to amniotic fluid, and then finally milk. The newborn gut has evolved around this continuum, and this is the natural progression of feeding. Preterm delivery interrupts that natural progression. We now have to put food into a system that should really only be ingesting amniotic fluid. We used to think that human milk was sterile, but we now know this is far from the truth. Human milk is characterized by an entire microbial community that interacts with and actually influences the infant intestinal microbiome. The entire biologic system that is human milk and its precursors is certainly more than just a source of nutrition. It's a very complex composition of macro and micronutrients, the carbs, the fats, the proteins, vitamins, minerals, trace elements, water, and likely other components that have not yet even been identified. But human milk is a source of many bioactive compounds, and those all play very important roles in human growth. And we are now just starting to understand how complex human milk is. We know milk is important for growth, but what are these bioactive components? Well, we know there are anti-inflammatory substances, oligosaccharides, digestive enzymes, antibodies, immunoglobulins, fatty acids, hormones, growth factors, antimicrobial factors, and hundreds of bacterial strains. And all of these components work together in symphony to provide the most optimal nutrition for growth and survival of human infants. The biological function of human milk is a result of this composition of all these components, perfect combination, and it truly is greater than just the sum of the individual components. As I talked about in the previous slide, human milk, especially mother's own milk, but also donor human milk, is a source of myriad bioactive components. These bioactives promote a healthy gut microbiome by stimulating the growth of commensal or good bacteria that compete with pathogens, and some actually bind with those pathogens so they can be eliminated in the infant stool. These bioactives also encourage cell maturation in the intestinal wall and so create tight junctions that prevent leaking from the intestinal lumen. Many of these bioactive components help to modulate the development and the regulation of a native immune system. The infant microbiome has been implicated in health trajectories that extend throughout the lifespan. But of course, feeding preemies isn't just a matter of giving moms milk and they grow well and they do fine. Human milk alone really is perfect for the term infant. But as I said, these infants have much higher nutritional needs, their GI tract doesn't function as well, and their expenditures are higher than their term counterparts, and I'll talk more about that later. They just can't tolerate enough volume to meet those nutritional needs. They require enriched feedings with higher macro and micronutrients than what breast milk alone can provide. When we start talking about enriched enteral nutrition options for very preterm infants, there really are three options: a cow milk-based preterm infant formula, human milk, mom's or donor milk that's mixed with a fortifier derived from cow milk, or human milk, again mom's or donor milk, mixed with a fortifier derived from human milk. So what are the recommendations when it comes to feeding these infants? As I'm sure you're well aware, breastfeeding and the use of human milk are recommended by several health organizations. A1, the Association of Women's Health, Obstetrics, and Neonatal Nursing's position statement includes the line, provisions should be made to support exclusive human milk diets, especially in vulnerable newborns. The American Academy of Pediatrics states human milk is uniquely superior for infant feeding, And the World Health Organization recommends breastfeeding, donor human milk when necessary, and human milk-based fortifiers for very low birth weight infants. And you might ask, really, does a choice of fortifier really make that much difference, especially if you're already using mom's own milk? Well, there is quite a disproportion in protein source between the two fortifier options. When mixed according to manufacturer's instructions to 2.3 grams of protein per 100 mils, if you're using a cow milk-based fortifier, actually 61% of the protein you're providing is a cow milk protein, and only 39% is human. Of course, if you're using a human milk-based fortifier, 100% of the protein is human milk protein. Now again, does that really make a difference? Does that really matter? It does appear that there is a definite dose-response relationship when cow milk-based product is added to the diet of an extremely low birth weight infant. Dr. Abrams et al. In a meta-analysis of 2 randomized controlled trials showed that for every 10% increase in a cow milk-based protein, there is an 11.8% increase in the risk of NEC, a 21% increase in the risk of surgical NEC, and a 17.9% increase in the risk of late onset sepsis. Where else do we see clinical benefits supporting those recommendations for an exclusive human milk diet? Well, feeding tolerance. Human milk is what human infants are supposed to be eating, and studies have shown that infants that are fed an exclusive human milk diet exhibit less feeding intolerance than those that are supplemented with cow milk-based products. Studies have also shown that an exclusive human milk diet impacts rates of NEC, sepsis, BPD, and ROP. Neurodevelopment, growth, and body composition are also impacted by diet choice, and we do know that body composition in infancy may have an impact on health throughout the lifespan, especially in metabolic syndromes such as diabetes. Let's take a little closer look at the evidence that supports those recommendations for the use of an exclusive human milk diet that includes mother's own milk and or donor human milk combined with a fortifier made from human milk. There have been numerous studies that have looked at the most common morbidities associated with prematurity and found significant decreases in NEC, cut by about 2/3, BPD, cut by 20% or more. ROP and late onset sepsis also significantly decreased in those fed an exclusive human milk diet compared to a diet that contained cow milk-based products. Studies have also shown a decrease in the incidence of patent ductus arteriosus requiring intervention in preemies that were fed an exclusive human milk diet. And this study out of Edinburgh showed the differences in hemispheric connections in the brain for 2 thresholds of human milk intake. Those infants that received exclusively human milk less than 75% of the days in the NICU on the left, and those that received exclusively human milk greater than or equal to 75% of the days in the NICU on the right. And you can see dramatic differences in those hemispheric connections. There was a definite dose-dependent relationship with human milk exposure, and this was independent of gestational age at birth. Now, I've shared with you the recommendations for what to feed, and I've shown evidence to support that. Now let's move on to the actual feeding administration part of this. The goals for feeding certainly are to meet the nutritional and the fluid needs enterally, so we can eliminate that need for parenteral nutrition. TPN has risks: central line infections, cholestasis, metabolic disturbances, just to name a few. It's also incredibly expensive. Because human milk is so well tolerated, remember, it's how babies are supposed to be nourished, faster feeding advancement is possible. So after an initial period of trophic feeds, if that's what your unit does, advancement of 30 to 35 mils per kilo per day has been shown to be safe and not increase the risk of NEC. Now, of course, it is important to always use clinical judgment and look at the entire clinical picture and consider risk factors for this particular infant, such as hypoxia, need for resuscitation, intrauterine drug exposure, and so on. Many units hold off fortifying feeds until the infant is tolerating 80 or even 100 mils per kilo per day. And this certainly has been standard practice in the past when using cow milk-based fortifiers. But numerous studies have shown the safety of starting fortification at an intake of 60 mils per kilo per day when using a fortifier made of human milk. And many are fortifying at 40 mils per kilo per day. Some even are starting fortification as early as 20 mils per kilo per day. And this has been shown in several studies to be safe. Beginning fortification at 26 calories per ounce, instead of using a stepwise approach that many are used to, starting at 22 calories per ounce, then go to 24, and then go to 26, for example, has also been shown to be well tolerated when using human milk-based fortification. And then once baby is tolerating about 50 to 60 mils per kilo per day in enteral feeds, most facilities will start weaning the parenteral nutrition. As enteral feeds increase, TPN decreases, trying to keep a desired volume for the day. Keep in mind, nutrient availability is much higher in TPN than in enteral feeds that have to be digested and absorbed through the gut. In an effort to compensate for this, adjustments in TPN concentration should be made, and enteral feeding fortification really needs to be maximized. This transition period just really is a delicate balancing act, decreasing one while increasing the other and still maintaining adequate nutrition for growth. Several studies have shown the benefits of concentrating TPN during that weaning process, focusing on the provision of adequate nutrients, greater than 3 grams per kilo per day of protein, at least 2 grams per kilo per day of fat, and at least 110 to 120 calories per kilo per day in order to support gluconeogenesis, to prevent nutritional deficiencies, and to improve growth. In our unit, we used to hear in rounds, well, there hasn't been much weight gain, but we're weaning the TPN, as if that were a good excuse. That should never be tolerated. A lag in growth means we are not meeting the nutritional needs of that infant at that time. Now, there are some arguments that folks don't want to concentrate their TPN in the event that now we have to stop enteral feedings and we've only got this concentrated TPN. We compensate for that by we concentrate our TPN. If we have to stop enteral nutrition, we just Y in D10 or D5, whatever it takes to meet those needs at the time for fluids while not over-providing the TPN, and then we can get the TPN ordered when that process takes place. Now, studies have also shown benefits to continuing lipid infusions longer than we traditionally have. Some guidelines are actually now recommending the continued use of lipids at 2 grams per kilo per day until that baby's taking 110 to 120 mils per kilo per day of enteral feeds. This is in an effort to meet those high lipid needs for brain growth and for brain development. And also remember that fat helps to stabilize blood sugar. And it's not uncommon to encounter episodes of hypoglycemia when you're trying to wean TPN or wean off those parenteral fluids. I want to talk about the variability in human milk and a bit about the impact of feeding administration, because what we think we are providing and what looks on paper like it should be meeting the baby's nutritional needs may not really be what the infant is actually getting. And in fact, we really don't even know exactly what the needs of this particular population are. I've already touched on macronutrient requirements for these preterm infants, but I'd like to talk about protein just a little more. Many of the bioactive compounds that I talked about earlier are proteins, and proteins really are the building blocks for growth and are critical for appropriate development. But interestingly, these protein recommendations that you see here really haven't changed for almost 20 years. The references have been updated, but they're still using data and recommendations that were published in about 2005. And yet this population we're caring for has changed dramatically. And so we don't really even know what their needs are, which really adds a little more complexity to trying to provide what we consider to be adequate nutrition. As I said before, we're doing the best we can with the knowledge we have available right now. We do know that human milk is highly variable. It differs between women. It is unique to her. It is influenced by her nutrition, by her environment, by her BMI, possibly by her genetic makeup. We know that milk differs across lactation, with higher protein in the earlier stages, higher fat and carbohydrates later. It even varies from morning to evening, from beginning of feeding to the end of that particular feeding. Human milk really is dynamic and ever-changing biologic. The other thing to consider is if you have a mom that's a very high-producing mom, the nutrients in her milk may be less than what you think it is. And if she had a term baby, that term baby would make up for those deficits in nutrients by just taking in more volume. That's the reason she's producing so much. Of course, preterm baby's not able to do that. And then we usually end up freezing some of mom's milk until that baby's intake increases to meet what she's producing. The freezing and thawing process also impacts nutritional composition, and especially some of those bioactive components to a degree. This is why some guidelines recommend feeding fresh milk whenever it's available, rather than sticking to the notion of feeding in order of pumping. That fresh milk is so important for these babies. And then we often rely on donor milk for these babies while we're waiting for mom's production to catch up to what we're providing. Most milk banks pool 2 to 5 donors in a batch. And when you think about that, the variability of just one donor can significantly impact that final product. Pooling of milk from a large number, let's say 100, 200 donors, really helps decrease that variability and provides a more standardized product. The method for the processing of donor milk and of fortifiers also impacts nutrient and bioactive components. And often the donor milk we're using isn't really analyzed. Most of us aren't analyzing mom's own milk, so we don't really even know what we're starting with before we're offering fortification. And even when donor milk makes claims regarding nutrients, unless it's guaranteed, unless it's been directly analyzed, we really can't be sure. Some of you are likely familiar with this study by Joe and colleagues that was published in the Journal of Perinatology not long ago. They looked at 75 samples of what was purported to be high-calorie donor human milk from 5 milk banks. The samples were all labeled as 24 cows per ounce by the milk bank of origin. But when analyzed, these samples varied significantly in their fat, their protein, and their calorie content. And in fact, the calories ranged from 16.5 to over 30 calories per ounce. Now, if we're providing standard fortification through our protocols using these milks, this really could result in gross miscalculations in nutrient intake for this baby. And then how we handle milk, preparing of feedings, administration, all contribute to nutrient loss. Milk fat especially, and to a lesser degree the other macronutrients, adhere to plastic. Freezing and thawing processes can affect nutrient content. And if you consider all the handling points along the way, from breast to storage container, freezers, thawing, measuring and mixing, sitting in syringes, flowing through extension sets and feeding tubes, to finally reaching the baby, there's a potential for significant loss of nutrition along the way. How feedings are provided also impacts nutrition that's received by the infant. Are you using continuous versus intermittent feedings? Extended feeding times, and I'm talking about longer than 30 minutes to provide that feeding. What type of equipment are you using? What type of syringe, eccentric versus concentric? What about your tubing length, your tubing type? What about the temperature of that feeding? And I'm going to talk about that a little bit more in a minute. And finally, the expenditures. What is using up those nutrients? All of this needs to be taken into account when you are trying to calculate what exactly the nutrition is that you're providing for this baby. Now, what about that intermittent versus continuous debate? Well, there are pros and cons to both. Continuous feeds are certainly more energy efficient, and they might be less stressful because there's decreased gastric distension. And continuous feeds seem to help mature duodenal contractions in the intestine. However, continuous feedings result in more nutrient loss during administration, so your growth might be affected. Intermittent feedings are more physiologic. They encourage splenic mesenteric artery flow. They encourage intestinal growth and encourage enzyme activity. Nutrient losses are less with intermittent feedings as well, especially with gravity feeds. But intermittent feeds do cause cyclical insulin surges. So if an infant is having significant issues with hypoglycemia, continuous feedings might be a better option, at least in the short term. And intermittent feeds do have the potential for gastric distension because obviously a larger volume is administered at a time. And there are several studies that have looked specifically at fat loss attributed to various feeding methods. The first in this table showed almost twice as much fat loss when the syringe pump was oriented horizontally versus vertically. Now remember, fat floats, so it's not surprising that the vertical syringe position had less loss of fat. The fat would rise to the top and be pushed out with the remainder of the feeding. The next one, Stocks, compared fat loss with bolus versus continuous feeds with a 17 and 34% fat loss respectively. Greer compared the fat loss at different continuous rates and found slower rates associated with significantly higher fat losses. Brennan found a mean calorie loss of almost 3 calories per ounce when continuous feeds were administered. And finally, Tabata showed a 20 to 25% fat loss with continuous feedings. It's obvious by looking at this photo of mom's milk in a storage bag how much the fat separates out and then adheres to the sides of the bag or the sides of the syringe or the sides of your feeding tube. And if you've ever tried to get all of that adhered fat out of that bag, it is next to impossible. Now I'd like to talk about a few techniques that may improve nutrition delivery to your babies. I think we've already ascertained that bolus feedings are optimal if the baby can tolerate that. But whether using intermittent or bolus feedings, you can optimize nutrition by using the shortest tubing length possible. I'm talking here about our extension sets. By using silicone tubing instead of polyurethane tubing. And consider priming the tubing with human milk cream. You coat the inside of that tube so less nutrients from your feeding adhere to the tubing. If you're using concentric syringes, those that have the offset tip, orient the syringe horizontally with the tip at the top. And if you're using eccentric syringes, those with the tip in the middle, orient that syringe vertically so the fat rises and is delivered first. And finally, warm those feedings to body temperature. I'm sure you're all saying right now, of course we warm our feedings. I'm sure you all do. You probably use a commercially available milk warmer. That's what I'm used to. However, I would certainly be lying to you if I said I've never pulled that feeding from the warmer a little early because I was in a hurry and I didn't want to wait anymore. Or more likely, I got busy the feeding warmed and then had already started to cool before I could get to it. But evidence has shown feedings may be better tolerated when fed at body temperature. Studies on animal models have shown cool feedings can result in total body cooling, decreased gastric and intestinal blood flow, GI mucosal injury, and poor growth. It's even been suggested that gastric cooling in very premature infants may increase their risk of NAP. Consider also that just based on physics, about 2.5% of the calories in a feeding are going to be used by the body to raise that milk temperature from room temp to body temp. Now combine that with the other potential nutrient losses that I've already talked about, and it brings me back to what I said earlier. What you think you are providing on paper may not be what your infant is actually getting. In addition to being attentive to what we're providing and how we're providing nutrition, we also have to be cognizant of where those nutrients are being used and how we can work to either conserve on those expenditures or adjust our nutrition to compensate. For example, hypothermia. Is your baby not gaining because he's being weaned out of the isolette when he isn't quite ready, and he's using his calories just to maintain his body temperature rather than to grow? What procedures or what treatments is the infant undergoing that might be causing stress or pain or inflammation? Has there been a change in respiratory support, and that's requiring increased expenditures just to compensate for that? Separation from the mother has also been shown to cause stress and agitation and thereby increase those calorie requirements. What about the environment? Are extraneous noise and lighting and other insults resulting in sleep deprivation and the use of those nutrients just for stabilization? Is this baby being disturbed every 3 hours just because it's time for us to do our cares? Regardless of taking a look at the baby and seeing if he's ready, routine nursing procedures, routine interruptions for an exam by a provider, those types of routine cares, even though we don't think we're being stressful to this baby, actually increase expenditures by over 10%. So what does it take? I'm a neonatologist that I worked with for several years. I like to ask this question often. He asked it about fluids, about nutrition, about respiratory support, about almost all the care that we did in the NICU. What does it take? He'd get all kinds of answers. 150 mils per kilo per day, 120 calories per kilo per day, perhaps a tidal volume of 4 to 6 mils per kilo. But his response was always the same. It takes what it takes. What we think we are providing may not be what the baby is actually getting. We have to consider the variability of our base milk, whether it's mom's milk or donor milk. We need to take a look at our feeding practices. Where are we losing nutrients along the way? What the infant is getting might not be what they're absorbing due to immaturity of the GI tract, immaturity of the digestive processes. And what we think the infant needs might not be considering the entire situation. This population has incredibly high nutritional needs coupled with high expenditures. A dietitian friend of mine says, if you're throwing the kitchen sink at them and they're still not growing, it's time to take a step back and rethink what we're doing because we're missing something. It takes what it takes. As I said, we're seeing a very new population of extremely low gestational age, extremely low birth weight infants in our NICUs. And I would expect that at some point that's going to stop, but who knows when. These infants have multi-organ immaturity and tremendous nutritional requirements, as well as tremendous stressors on other resources that we have in our NICUs. What we are feeding can impact their outcomes. human milk is species specific, and human infants are supposed to be nourished by human milk. The bioactive components that are found in human milk are critical for their growth and development. Our goals for these babies should not be just their survival, but good outcomes. We should be focused on relieving those burdens of prematurity where we can. The burdens on the infant during their NICU stay and their ongoing quality of life. The burdens on the family when they're trying to care for this infant and at the same time juggle other responsibilities such as siblings or other family members and workloads. The burdens on our communities and our societies as a whole in ongoing healthcare costs, resource utilization, and long-term health trajectories. So remember, optimizing care of the premature infant is truly an investment in the future, not only for that baby, not only for that family, but truly it is an investment in the future for all of us. And now I would love to answer any questions that you might have. Okay, I had a little interest glitch there, so I don't know if you were hearing what I was saying earlier, but those babies that are extremely premature, that are extremely critical, you might start with 10 mils per kilo per day and advance by 10 mils per kilo per day until you reach your full feeding volume. For those that are just very premature but have kind of standard risk protocols, they haven't experienced hypoxia, they haven't required resuscitation, they didn't have extremely low APGAR scores, those type of things, it would be customary to start their feedings at maybe 10 mils per kilo per day for the first few days and then increase by 20 mils per kilo per day. And for those little bit bigger babies, it certainly would be okay to start faster, start at 20, start at even 30, and that's been supported by the research, and then continue to increase by 30 mils per kilo per day. And especially if you're using an exclusive human milk diet, babies do seem to tolerate that quite well. But you can look online and find some other feeding protocols if you're interested.
Thank you, Mindy. And I think we might have had some audio difficulties at the beginning of our question session. So just Mindy was speaking about standard feeding protocols for those of you that missed the beginning piece of that. I also wanted to know, or this is one of the questions that also came in, is what volume of cream do you recommend for priming tubing?
You would want to evaluate how much volume does your extension set hold. So, because there's going to be a difference if you're using a regular extension set versus a microbore extension set, and you would want to flush with whatever volume that is. So what I am used to using takes 0.5 for a volume, so I would flush with 0.5 just to get that tubing filled, make sure I've got it well coated, and then hook up my feeding and progress with the rest of the feeding. The volume that's in that remaining in that tubing is going to be negligible, so we don't flush that out and then proceed. We just leave what's in the tubing and then start our feeding and progress from there.
Great, thank you. Another question is, do you have any evidence on the comparison of the components between donor milk and mom's own milk?
You know, there is quite a bit of evidence that's out there that talks about the effects on the pasteurization process for donor milk versus mom's own milk. And there are several resources if somebody wants to reach out directly, but Meredith Dennis has one, Lima has one. There are several resources out there that compare pasteurization processes, which certainly pasteurization does have an impact on milk, and different pasteurization processes have different effects. And so those are certainly available online. If you look up effects of pasteurization on human milk, you will find many. Also, I'd be delighted to discuss this more if anyone wants to reach out to me directly. That would be a great conversation to have. But again, processing of milk, again, is a whole nother, could be a whole nother presentation, but absolutely donor milk is not the same as mom's own milk. It is just different depending on what process is used, but also, as I said, varies from mom to mom. And a mom's own milk is very specific to her own infant, and there is that reciprocity between mom and baby. Baby is stimulating mom, and then mom is producing in effect to what that baby needs, wants, is exposed to. Now, certainly that leads us to, of course, the baby needs to be at the breast and supporting that non-nutritive suck, even at a very early age when baby is being gavage fed, because it stimulates that mammary system, and then mom can produce according to what her baby needs. And that is one of the reasons that mom's own milk is absolutely most critical for that baby whenever it's available in whatever quantity it's available in.
Great. And now I'm getting a lot of questions that I'm not sure we're going to have enough time to answer all of them. So I just want to mention that Mindy will be able to answer you directly if we're not able to get to your question prior to the next few minutes. But there were a few questions around NEC and the evidence supporting the use of all human milk, including the human milk fortifiers, and the effect on NEC. Could you comment on that?
Sure. You know, NEC is a big deal, and it is one of the most horrible conditions that you can encounter in the NICU. It's horrible from the baby's perspective, from the parent's perspective, and certainly from our perspective as clinicians. And a high mortality rate or high morbidity rate as a result of NEC. So anything that we can do to decrease that risk for the baby, understanding that we are likely never going to be able to prevent it entirely. That's likely unrealistic, at least in the near future. But whatever we can do to help prevent it, and there are numerous studies, as I showed back on that comorbidity slide, and there are others in addition to that support exclusive human milk diets do decrease the risk of NEC. There is some question of whether it is the human milk component that decreases the risk, or it's the avoidance of the cow milk products that impacts the risk. But there are numerous irrefutable studies that show a decrease in NEC and certainly a decrease in surgical NEC. And I do believe Crystal is making these slides available as handouts for anyone. And if you look on that comorbidity slide, it does have studies listed on there that you could certainly reference. And again, if you want to reach out directly, I'd be happy to talk more about that. But human milk diet certainly has been shown in many studies to decrease the risk of NEC.
Thank you, Mindy. And it looks like we maybe have 1 minute left for a question, and there were several questions about cream, the use of cream, and do you prime your tubing with fat and cream prior to each feeding, or just at the beginning of the life of the tube?
So because we change our extension sets with each feeding, then priming, of course, prior to each feeding is appropriate. There are some places that reuse their tubing. They might use it for a 12-hour shift. Then you could prime it just that one time as you're putting feedings through it. That tubing is going to be coated. However, depending on what you do with that extension set between feedings is going to impact it. Some places just flush with air and then use it. There are some places, which I do not recommend, that actually leave it connected and then hook up their next feeding, because you're leaving all of that milk at room temperature in that feeding without moving, or in that extension set without moving. Could lead to bacterial growth. I'm thinking that in my head. I don't know that that's been studied, but I wouldn't want to myself take in milk that's been sitting in a tubing since my last feeding and then push that in or push it into my baby. For those that are using continuous feeds, each time that we put up a new extension set, we'd want to flush that. If you're flushing your tubings with water or sterile water in between feedings, you are possibly getting some of that fat washed off the tubing. I think it would be negligible, but I would still, if I were flushing with water, and I would reflush that with cream just to be sure it's coated and I'm not losing those nutrients.
Great, some great tips that you mentioned there. Well, that concludes our time available for questions today. I want to thank Mindy for such a wonderful presentation and for answering a lot of really detailed questions. And we have several more. And like I mentioned, we will have Mindy reach out to you with an answer at the conclusion of the presentation. Thank you, everyone, so much for attending today. And we will see you at our next webinar.
Thank you, everyone, so much for the questions and for attending today.